So with that, I'll go into our first debate, which is a really important topic because so many of our patients always need steroids or other immunosuppression, either to treat side effects or to treat different aspects related to their cancer. And so we have two different sides of this debate. This is a question of, does immune suppression, specifically steroids, because that's the most common immunosuppressant that's often used, does that hurt the efficacy of checkpoint blockade? And we have two different perspectives on this, and this is a controversial area. We don't really know the exact answer in every context, but we'll hear a couple different points of view from those that have done research in this area. And first, Kathryn Arbour from our thoracic group. As soon as the slides come up, we'll talk about kind of taking the point that immunosuppression actually does diminish the efficacy of checkpoint blockade. So let's get our slide, and then we'll get started. I think it's the number 4. Great, thank you, Casey.
So good morning. Thank you for the opportunity to talk about this. This is the first debate of today, so hopefully we'll have a lively discussion. And we'll talk a little bit more about how do we manage our patients kind of in this setting outside of the clinical trial context, which we've heard a lot about so far today. I've been tasked to argue that immunosuppression does diminish the efficacy of immune checkpoint blockade. And what do we know? I'm a thoracic medical oncologist, so I'll focus on our experience in lung cancer. You heard from Dr. Hellman earlier about the role of single agent and combination PD-1 and PD-L1 inhibitors in patients with lung cancer. While many of our patients receive therapy in combination with chemotherapy now, a good proportion still receive single agent immunotherapy, and so it's very relevant for our clinical practice. And then obviously patients who've received chemotherapy in the past and who have progressive disease may still be receiving single agent pembrolizumab, nivolumab, atezolizumab approved for the treatment of progression of disease after chemotherapy. But sometimes our patients are also on immunosuppressive medications. In immunosuppression, there are many different categories of therapies. Steroids, as Dr. Pasto referenced, are a big category of this. Also people who are on other immunosuppressives, for example, for autoimmune conditions, anti-TNF agents, antimetabolites like methotrexate, and other biologics, and there seem to be more and more in development all the time for a variety of conditions. Focusing on steroids, though, steroids falls into the category of an immunosuppressive medication, which is also commonly used in cancer care, not for the treatment of autoimmune conditions, but for the treatment of cancer-related symptoms. And corticosteroids can rapidly provide relief and palliate a number of cancer symptoms and are used and have been used fairly liberally in lung cancer patients in particular. They can rapidly help symptoms like dyspnea, fatigue, anorexia, pain even, and then brain metastases are common in our patients, and so the symptoms and edema associated with that, they're an important tool. But we've been long concerned about the potential toxicities of long-term steroids. My patients wonder why they can't be on Dex just constantly forever. And the truth is we've been worried about things like hyperglycemia in our diabetic patients, fluid retention, muscle wasting, and ultimately immunosuppression, though for a long time our concerns about immunosuppression were related to infectious risks. So we put patients on Bactrim prophylaxis to decrease the risk of PCP pneumonia. What about the flip side of that? For patients who are on immunosuppressive medications like steroids, what is the effect on the PD-1 and PD-L1 inhibitors that they're taking? So we know, first of all, I'm talking about steroids and immunosuppression medications prior to the start of therapy, not talking about steroids used while someone is on treatment for the treatment of immune-related adverse events. We know that they can be serious medical issues, even medical emergencies leading to death, so it's important to manage those symptoms aggressively when those problems come up. But what about the patients receiving steroids prior to treatment, those patients that are on steroids in your clinic and you're thinking about starting a PD-1 inhibitor? Well, we quite frankly know very little from the randomized clinical trials or really any clinical trials. It was almost a universal exclusion criteria among all of these trials that if someone was on prednisone greater than or equal to 10 milligrams or its equivalent, they were not eligible for the clinical trials across lung cancer and really multiple diseases. There is been concern that this immunosuppression with steroids could decrease the likelihood of effect of these drugs. That's why that exclusion criteria was in place. And as far as the mechanism of action of these drugs, it may include a proliferative burst of CD8 positive T cells and could being on immunosuppression, including steroids, kind of blunt this effect in response. So we set out to answer that question with our lung cancer group here, or at least try to address it in the context of the data that we have available. What is the efficacy of PD-1 and PD-L1 inhibitors in lung cancer patients receiving baseline steroids, which is, again, our most common immunosuppressant that we're using in clinic on a routine basis? And to answer this question, we really look to real-world data. So we have a large experience of lung cancer patients treated with PD-1, PD-L1 inhibitors. We've tracked these patients over time, and given that we were a part of the initial clinical trials, we have a large group of patients that were treated and can really study their experience in the real-world setting outside of the context of a clinical trial to get more variety in the patients that we're seeing. And this was a cohort that we looked at that was nearly 500 patients. Our experience here is up to 1,600 patients now. So we really have the ability to look at these questions. And then we had a separate cohort from Gustave Roussy Cancer Center that was interested in asking similar questions. So we did a retrospective review of patients who were treated with non-small cell lung cancer with a single agent PD-1 and PD-L1 inhibitor, and reviewed medical records and pharmacy records to determine if any of these patients were on steroids on day 1 of treatment. We selected a cutoff of equivalent of 10 milligrams of prednisone daily, given that that was the standard kind of cutoff that was used in all clinical trials. And if a patient was on that on day 1 of treatment, they were considered to be on baseline steroids. And we looked at duration of steroids and dosing of that too. The outcomes we looked at were things that we would look at in a clinical trial: response rate, and all patients had had formal response assessments by RECIST, even our real-world data-treated patients, so we can kind of rigorously look at those outcomes, and then progression-free survival and overall survival, and tried to tease in, are there other factors and subgroups that may be benefiting or may be particularly worse off with steroids. Here we can see the patient characteristics here, and I'll point to, this is our classic lung cancer population in which we see more former smokers, but some never smokers, and a variety of performance statuses, our excellent performance status patients, as well as those with an ECOG performance status of 2 or more. The indications for using steroids, about 12% of the Memorial cohort and 20% of the Gustave Roussy cohort were receiving prednisone 10 milligrams or greater, and the indications for steroids were variable. So brain metastasis and management of those symptoms was certainly there, but so were things like dyspnea, fatigue, and pain, those other common symptoms that we can quickly palliate with steroids in clinic. So how did these patients do? Well, when we looked at both cohorts, in patients who were receiving baseline steroids, the response rates were lower, only 6% in the Memorial Sloan Kettering cohort, and in the Gustave Roussy cohort, 8%. And so it's a pretty similar trend in both groups for patients receiving baseline steroids having worse outcomes. And this we saw also in terms of progression-free survival in both cohorts and overall survival. And I think between these two independent cohorts, kind of striking similarities that we're seeing in terms of worse outcomes for patients on baseline steroids. Are there any subgroups that are benefiting? It seemed like across all of them, in terms of progression-free survival and overall survival, favored the patients who received no or low steroids. And we tried to do a multivariate analysis adjusting for the features that were significant in univariate analysis. Those included smoking history, performance status, history of brain metastases, and also steroid use. And we found that adjusting for these other features, that steroid use continued to be associated with shorter progression-free survival, shorter overall survival, and also lower overall response rate. So is there a safe dose of steroids? It's hard in these real-world cohorts when the overall incidence of steroid usage is relatively low, but if we try to tease off a date, let's say a dose, let's say 20 milligrams, is that worse than 15 milligrams? And when we grouped that, the lowest response rates were seen in those patients who were on greater than or equal to 20 milligrams of prednisone at baseline, but the responses even in the intermediate group, the 10 to 19 milligram dose, and most of these patients in that intermediate group were on 10 milligrams of prednisone, with still only 10%. And what we can see here, we saw in progression-free survival and overall survival shown here, even those patients on an intermediate dose of steroid had worse overall survival and progression-free survival, though the worst outcomes were seen in patients on higher doses of steroids. Does the duration of steroids matter? So if you just started steroids 2 days before going on treatment, or 15 days versus greater than 30 days and you've been on it for months, does that influence how you respond? And so we used a cut point of 30 days. And for those patients who had been on steroids longer than 30 days prior to treatment, that this was really long-standing steroid use, those patients had the worst outcome, with 6% of patients having only a response, and in terms of overall survival and progression-free survival, so we see the same trend. So in this mind, higher doses of steroids, somewhat worse, but still seen in lower doses, and same thing with the duration. What about the indication for steroids? So I've focused on our work that we've done, but recently the group at Dana-Farber published a series that looked at the indication for steroids. So nearly every patient in our cohort was on steroids for the treatment of cancer-related symptoms. We did not have really any patients who were on it for rheumatologic conditions or other indications. And so they asked the question, what about our patients who are on steroids for cancer-unrelated conditions? They classified them as people who are on steroids for COPD, getting pre-medications for IV contrast, a rash, rheumatoid arthritis. What does it look like in that situation? And what they showed is that for patients who are on steroids for non-cancer related issues, their response rates were actually similar, and their progression-free survival and overall survival were similar to the overall group. But they did see overall and in the trend for patients who were on prednisone and steroids for their cancer-related conditions, similar trend in terms of response rate and overall survival and progression-free survival. So in this debate, again, I was tasked with, does immunosuppression, specifically steroids, diminish immune checkpoint blockade efficacy? And I would argue yes. Baseline steroid use we showed in our group, and again, these are patients that we don't have data from clinical trials. They weren't a part of that group. So how do we study those patients? But we see that they have inferior outcomes in terms of response rate, progression-free survival, and overall survival. This effect may be predictive, it may be suppressing the response to therapy, or it simply may be prognostic. We completely acknowledge that from this work. But regardless, the outcomes are striking in terms of the patients that were on steroid dosing. And therefore, based on this work and how it influences our clinical practice within the group, and my clinical practice in particular, I use steroids prudently in patients who are on PD-L1 blockade, or if it's planned for my patients. I consider non-steroid alternatives for the management of cancer-related symptoms, not only for all of the toxicities that we talked about before in terms of hyperglycemia, muscle wasting, and the risk of infection in that group, but also for patients who are planned to be on single-agent immunotherapy. I think about other approaches. However, there are some conditions where we simply can't manage with other approaches. If someone needs to be on steroids for their brain metastasis, they need to be on steroids for their brain metastasis. And so certainly medically necessary steroids should not be avoided, nor, as we discussed, this is really talking about baseline steroids, not the management of toxicity. Ultimately, as Dr. Hellman outlined, that many patients are receiving chemotherapy and PD-1 and PD-L1 in combination. And so this really only applies to those patients receiving single-agent PD-1 inhibitors. We're interested in looking at this question in patients receiving chemotherapy and immunotherapy together, and leveraging in our experience at Memorial, we're hopeful to kind of have more ability to answer these real-world data questions outside the context of clinical trials, where our patients might not fit the perfect picture of a clinical trial patient. Thank you.
Great job, Casey. It's a little bit, makes me a little nervous to see all of this, actually, especially because we give pre-medications to a lot of our patients getting chemo and immune therapy. So can you address that briefly? And if others have questions, just raise your hand and we'll get the microphone up to you.
Yeah, so the pre-medication issue is a really important one. We don't use steroids for pre-medication for single-agent immunotherapy, obviously, because it's not thought to be immunogenic, and certainly that isn't part of our standard regimens. But many patients are receiving, most patients, quite frankly now in terms of lung cancer, are receiving combination chemotherapy and immunotherapy. Those include typically high doses of steroids as a part of carboplatin-containing regimens or paclitaxel-containing regimens. Whether or not those patients, maybe that's a short dose right at the beginning, maybe that doesn't matter. Maybe the chemotherapy overcomes that in terms of some inflammatory response, but we still are seeing excellent outcomes in this patient, so that remains to be seen. There's a question of what is the steroid dose if we had regimens with lower steroid doses in terms of the chemotherapy partners, would that be more effective? And we haven't seen differences in outcomes in terms of chemotherapy regimens from one to another in terms of steroid dosing. So it's certainly a question. Ultimately, some of this effect may be prognostic. Maybe these patients are just quite sick and requiring steroids. And that's something that we definitely need to acknowledge. But for many reasons, for those patients who don't need to be on steroids, maybe we can avoid them.
Thank you. Just fantastic talk. Have there been any observations on the incidence of immune-related toxicity in patients who are already on steroids prior to starting immunotherapy?
It's a good question. The challenge is that relatively few patients in this series, at least, are on steroids prior to the start of therapy. And those patients who are on steroids for the therapy that might be, let's say, have autoimmune conditions for those purposes, we would worry about those patients having increased risk of immune-related adverse events afterwards. So there are some series that have shown that in patients with autoimmune conditions or a baseline, the patients who are on immunosuppressives may have a slightly increased risk of flaring, but that just might be a function of their disease being worse at baseline. So I don't think it makes sense to put people on it prophylactically to prevent the immune-related adverse event, but we use steroids liberally for the treatment of severe problems related to that.
Thank you.
That's great. I should probably, in the sense of harmonizing among different disease groups, we should probably point out that in the melanoma world, the data are exactly the same. That patients who are on steroids at the beginning, the response rate to anti-PD-1 is about a third. So it's again, we don't know if it's prognostic or mechanistic, but I do worry about the pre-medication with the chemotherapy. I think it's a kind of a universal now observation of steroids.
Yeah, absolutely. And I think, the challenges with the chemotherapy regimens that we use, at least for lung cancer, in addition to hypersensitivity reactions, nausea and vomiting, we've done so much impressive work over the past decades to make these regimens tolerable and to aggressively try to make constant vomiting related to these regimens, manageable in that setting. And so it's hard to kind of dial back on those. But I think it's important to consider going forward. We just don't have enough data just yet.
A lot of protocols allow 5 to 10 milligrams for all those miserable joint pains and other things. And I'm just wondering whether anyone has looked at that 5 to 10 milligram range as in the symptom support domain.
Yeah, absolutely. So, in the 5 milligrams, I guess would be the most common dose just in terms of dosing that we have for patients who are on it. But, we largely consider those doses, or we have largely considered that dose as physiologic, right, in terms of that low dose that people are on. Sometimes our rheumatologic patients have just a chronic low dose steroids that they're on. In our cohorts that we looked at across both groups, it was an incredibly small number of patients, like 9 patients in groups across hundreds and hundreds of patients. So we weren't able to tease out those outcomes. And given the thought that those were physiologic and those patients were treated as a part of the clinical trials, we didn't include those, but it's a good question.
So this point was brought up earlier, and you alluded to it as well, about patients that are on steroids as being sicker patients, and then perhaps that's really feeding into the poor prognosis, or perhaps even the response. But do you think there's a way of looking at the data or going forward how we can answer the question of whether it's just patient selection, especially in the majority of solid tumor settings?
So I think it's a really good point. We've heard that, and I certainly do acknowledge that sometimes these patients are just very sick and they need steroids from that standpoint. I think that as we treat larger and larger numbers of patients, we'll be able to tease out, especially that poor performance status patient of an ECOG 2 as opposed to an ECOG 0 from that standpoint. So I think that that's a really important thing. But I would argue that some of the symptoms that are troubling in terms of the illness from these patients, in terms of fatigue, appetite, are something that we can make better with steroids. But it's really about the underlying disease problem that's leading to those things. And so we need to get the disease treated rather than starting someone on steroids and briefly boosting their appetite, but perhaps harming our ultimate therapies that we're on. Other things like steroids for brain metastasis, obviously that's a different situation. But for things like pain, there might be other ways for us to manage the pain rather than steroids. Same thing with fatigue and appetite. And that's what I try to do in my own patient population, thinking about other ways to manage the symptoms, especially if I know that a checkpoint inhibitor is going to be in their future for therapy.
So would looking at this in a chemotherapy-only cohort get you at that prognostic versus predictor?
So that's absolutely the case. I think there's, in terms of the prognosis for patients who are on baseline steroids from that standpoint. The steroid dosing with chemotherapy is slightly a little bit different because people are on steroids right before and then duration after. So they're intermittently on steroids, so that clouds the picture a little bit during that. Different tapers, different regimens.
Thank you.
Thanks.
So we'll have more time to talk about this on our panel, but I think it's important that now we think about the other side. So from the other side of the aisle, Maggie Callahan from our Melanoma and Immunotherapy Service will be telling us maybe steroids aren't so bad, or at least in certain contexts, and specifically around immune therapy toxicities.
So thanks so much for inviting me to be part of this panel discussion, and one that we've formatted as a debate to bring out, I think, some really interesting clinical discussions, and I've been tasked with identifying areas where immunosuppression may be used and doesn't diminish immune checkpoint blockade efficacy. I will say I feel a little like I'm on the side of defending smoking safety, especially because I'd like to acknowledge the great presentation that Casey did, and I think the near universal data we have that being on immunosuppression for treating cancer-related symptoms, or for treating autoimmune disease, or for any number of reasons, brain metastases prior to the initiation of checkpoint blockade, is likely a liability in terms of the efficacy of checkpoint inhibitors. That said, as Casey alluded to, and what I'll expand on in my side of the debate, is the myriad situations where even if we might not, in an ideal world, want to use steroids in our patients who receive checkpoint inhibitors, where our best clinical judgment says that they're needed, and how can we navigate using these tools? And here I'll say, as physicians, we're really obligated to put on our thinking cap and say, we can't just uniformly say you can never use steroids. Clearly there are specific scenarios where steroids are needed and are in the best interest of our patients. To that end, I'm really going to focus very specifically on the situation of immune-related toxicities that develop in our patients who are given checkpoint blocking antibodies. And I think, as the audience is well aware, and I think several panelists later in the day will talk about in some more detail, there are serious toxicities that can develop in patients who receive these immunotherapies. And the way I describe it to my patients is, we're going to give you these medicines to activate your immune system. Our hope is that your immune system is going to fight your cancer, but in all truth, we don't have a tremendous amount of control over what your immune system may do, and it's possible that your immune system will attack normal organs and cause damage and injury. And some of the toxicities that we've seen in our patients include colitis, myocarditis, pneumonitis, hepatitis, uveitis, nephritis, encephalitis, or other neurologic toxicities. And these can be quite serious and even life-threatening toxicities. And the empiric treatment of these toxicities has been to treat them with steroids, which generally is effective and really one of the most commonly used and effective ways to treat and reverse these side effects. Sometimes additional immunosuppressants like TNF blocking antibodies can be used as well. And then there's one particular class of toxicities, endocrinopathies, that result in the deficiency of endogenous steroids that require steroid supplementation, and they're hypophysitis or adrenal insufficiency are cases where mechanistically we really are called on to use steroids because our patients no longer can make their own endogenous steroids. In this space, the data is limited, but I'll highlight, I think, one of the larger published experiences looking at this intersection between immune-related adverse events, the need for systemic immunosuppression, in this case mainly steroids, and how this affects the outcomes of our patients treated with, in this case, ipilimumab for the treatment of melanoma, work that was headed by Dr. Chapman and colleagues, and reflects the experience at Memorial Sloan Kettering. And here we evaluated the experience for approximately 300 patients with melanoma who received ipilimumab for the treatment of their melanoma. Approximately a third of those patients had toxicities that required the use of steroids to treat them, 103 patients, or 35% of the population. And amongst those who had toxicities, about a third of those also received anti-TNF blocking antibodies. So this highlights how commonly patients develop toxicities that require steroids for their safe treatment. In the paper, our group looked at the relationship in a landmark analysis between toxicity and overall survival and treatment failure-free survival, as well as the use of steroids or not, dividing the group into those who had no steroids or those who had steroids. And in this case, again, these are not patients who received steroids prior to initiation of ipilimumab treatment. These are patients who received steroids for the treatment of their toxicity that developed after initiation of ipilimumab therapy. And what I think clearly comes across here is that whether you receive steroids or not, it does not influence your likelihood of survival after treatment with ipilimumab, and likewise, the likelihood of a treatment failure is not adversely affected by the appropriate use of steroids to treat toxicity. Another way that we might be able to look at this data in a complementary and indirect way, because again, we just lack prospective data for this analysis, but we now do have long-term survival follow-up in patients who received immune checkpoint blockade. Here I'm presenting 4-year survival outcomes. And this is a data analysis where they looked at patients who discontinued treatment because of a serious adverse event or did not discontinue treatment. And this is an indirect way of looking at the question of steroid use, but patients who have to discontinue treatment because of a serious adverse event are almost always patients who receive some sort of immunosuppression. And what you see again here in looking at the analysis in survival and in the smaller inset progression-free survival is that patients who discontinue treatment, and I would argue by proxy patients who receive appropriate immunosuppression for treatment of an adverse event during immune checkpoint inhibitor treatment are not, don't have inferior outcomes with regard to overall survival or progression-free survival. Now, there are a number of really important questions and nuances that are missed in these data sets. Whether certain subsets of patients do have inferior outcomes, or whether there's a more nuanced way to look at this in terms of level of immunosuppression, I think are real unmet needs here. And what I will say is in clinical practice, I think we've all had anecdotal experiences, some of which have been reported in the literature, either of patients who have a great response despite the need to get steroids, or have apparent loss of their response when immunosuppression is initiated. In this case, I've highlighted a case that was published in the New England Journal, and purposely picked this because this is actually the use of an IL-17 blockade and steroid alternative associated with loss of treatment response. Making the argument that probably steroids alone are not the bad actors, but more broadly, we need to better understand the myriad ways we can modulate the immune system to reduce the risk of toxicity but preserve anti-tumor effect. And I think we're still in the very early stages of understanding how to do that best. And while there are real virtues and a real need to understand alternatives to steroids, just because it's an alternative to steroid doesn't necessarily mean that's going to be the optimum way to preserve anti-tumor response. The second part of my presentation, I'd like to talk about a very specific scenario where steroid use is almost mandated, and this is one very peculiar toxicity associated with immune checkpoint blockade, endocrinopathies that affect the adrenal axis. And here we're talking about either hypophysitis, which can compromise the function of the pituitary, lead to diminished ACTH, and then diminished endogenous steroids being produced, or a direct effect on the adrenal gland, which can also likewise reduce the patient's ability to produce endogenous steroids. And untreated and unsupplemented, these patients can go into adrenal crisis, and this can be quite a serious outcome. I don't think there's any question that these patients require replacement steroids at a minimum. And our practice typically at Memorial Sloan Kettering has been to replace these patients, but not give them high-dose steroids in an effort to reverse the hypophysitis. I mention this in particular because I'd like to take this idea that we need to take a nuanced approach to immunosuppression a step further and perhaps undermine my own argument that it's safe to give steroids for management of toxicity by presenting this manuscript coming from Ryan Sullivan's group, where he took patients who developed hypophysitis, and then he fractionated those into patients who either received low doses of steroids, mostly falling within the realm of these physiologic doses of steroids that we would consider as steroids given for replacement of endogenous steroids, versus patients who received high doses of steroids, steroids that exceed what would be needed for replacement of endogenous steroids. And when he fractionated these two groups, admittedly somewhat small numbers, but what you can see is that patients who received the lower doses of replacement steroids had superior outcomes to those who received high doses of steroids. And this is true both in looking at survival and also looking at treatment failure. And so I think that what we can take from this analysis is not so much that it undermines the notion that we should treat adverse events and that steroids and other immunosuppressive agents are important tools in our arsenal, but simply that we need to right-size our approach to the treatment of toxicities and, as Casey alluded to previously, judiciously use immunosuppression and look for alternatives where we can safely find them, but not be afraid to use steroids when they're truly needed for life-threatening toxicities. And I'll thank you, and I think we have a panel to follow.